Thank you for attending this session. Please help me welcome Dr. Antonio Jacob, who will present on maximize your results with in-house direct print aligners.
Good morning, everyone. My name is Antonio Jacob, and it's an honor for me to speak at the AAO. I'm an orthodontist with 26 years of clinical experience, and I also have a master's degree in implantology, which helped me in the reasoning behind the reverse planning during the production of digital orthodontic treatment plan. I have a private practice in Belo Horizonte since 1999, and I run a small digital lab. I want to thank the organizing committee for the invitation and opportunity, and also Melissa McCullough for all the help and instruction for the speakers. We do have a conflict of interest to disclosure. I'm a clinical advisor at Archform Incorporation, and you are going to see during the presentation some images of the software that we use on a regular basis to production of our in-house aligners. And I have no conflict of interest with any other companies or materials shown in this presentation. Well, I'm from Brazil, which is the country with the highest number of dentists in the world. I don't know if you know that, but according to the Federal Council of Dentistry, CFO Brazil surpassed 400,000 dentists and in the early 2023, and we have over 30,000 orthodontists. My city is Belo Horizonte in the states of Minas Gerais, which means beautiful horizon, as you can see in this picture. And it's one of the best places for mountain biking. We are famous for producing a specific cheese, and we produce 1/3 of the coffee consumed in the world. If you come and visit us, it will be a pleasure, so we can have a coffee and discuss about orthodontics. It will be my pleasure to receive you there. Well, we are going to speak today about how to maximize our results with in-house direct printed aligners. In this presentation, we will explore the innovative world of in-house direct print aligners and cover the key aspects, including the workflow, the treatment planning strategies, shape memory polymers, clinical applications, the design, and the future directions. We will begin with an introduction of in-house aligner, discussing the differences of a traditional aligners and the benefits of in-house production. Next, we will examine the workflow involved in the production of these aligners, including the advantages in technology and sharing, staging strategies of treatment planning. Following this, we will address the new materials and their properties on treatment outcomes, clinical applications, and the new possibilities to design and improve our result, the shape memory polymers, clinical applications, and future directions and conclusions. So we kind of have an evolution in orthodontic therapy with clear aligners. It's like a digital transformation in dentistry. And it's important to have a rationale of digital planning involving materials and use hybrid mechanicals, and the clinical expertise of the orthodontist is super important. The 3D printing technology has evolved a lot, so nowadays we have a cost reduction, lots of material innovation and software advances. The intraoral scanners also have evolved, and it's interesting to know the right technique to scan to have the best quality meshes, and it's important also to see and to analyze the possible errors during the scanning process. Also, the cone beam CT, it's very interesting for us to have a visualization of the software and know how to interpret the cone beam images. Today we have also the evolution of facial scanners. You can have traditional or conventional or app-based that some applications are free to download, and it's quite interesting. The possibility of customization today using in-house aligner is very easy to customize the treatment plan for each patient, and the possibility to deliver the aligners at the same day. And the monitoring systems that have a smart STL technologies that the patient can generate an STL over a first STL and in a distance. So this is quite amazing. So today we just can have a diagnosis with a facial scan, a cone beam CT, and we can merge all of this into the software. So in the future we'll have the possibility to make all the treatment plans seeing the roots, and we can have better treatment plans using all this technology. So this image looks real, but it's AI generated. And instead of fighting with the industry, it's better to work together to get better results for our patients. So this is an image created by ChatGPT, and the situation of an orthodontist that fights against the industry. But anyway, it's better to work together for better results. So at least we have the appropriate tools to produce our aligners. And to demonstrate the workflow for direct print aligners, it's important to remember the workflow for traditional thermoformed aligners. The workflow for producing traditional aligners involves the 3D printing of the models to thermoform the aligner. So we'll have an export of the model that can be printed horizontally, vertically, can be hold, can be solid. You can define which preference do you have and export the model. Then you, of course, will have the scan first, then we have to plan and print the models. After that, of course, we need to wash and post-cure. There are resins today that are washed with water or alcohol, depends on the type of resin that you buy. Then we need to thermoform the aligners, cut or trim with the scissor, or mills with some machines that can do the trimming for you, and of course the polishing that we will deliver. So the complete workflow will scan the patient, do the setup, scan the patient like 10 minutes, set up in 45 minutes, print the models, depending if you print horizontally, about 90 minutes, wash and post-cure, another 25 minutes, thermoform, another 5 minutes, trim, mills, another 5 minutes at the end, we'll polish. So at the end, we'll have something around 3 hours to produce a thermoformed aligner. And the workflow for producing DPAs involves several key steps from digital scanning to the final product, and it's very important to understand the process that is essential for maximizing efficiency and effectiveness. So this article, published in 2014, is one of the first papers that demonstrates a shell formation from a model to produce a direct printed retainer. The STL file was sent to a 3D rapid prototyping machine, and it was a selective laser sintering machine, and this retainer was made with a material called fine polyamide. So before that, now we can export the shells instead of the models. And this possibility, it's very interesting now because it's a little bit faster and some key steps that we don't need to use anymore. So we will scan the patient, do the setup, and then we print directly the aligners. And we have some differences that I would like to show up. So one of them is the centrifuge, the post-curing, and with nitrogen generator and the polish at the end. So let's understand that in this case, we can set up a trim line. And this paper is interesting because according to this article published in 2023, a straight extended trim line may improve the clinical outcomes. So as we can choose inside the software, you can determine what type of trimming would you like. So you can use the scalloped. You can use 1 millimeter from the gingival margin, 2 millimeters or 3 millimeters extended, and you have these control points that you can also design whatever you like or the shape of the aligner. So after that, we just go into the printer. Here we would be able to place 10 aligners in one at once, and we can define the print resolution of 50 micrometers or 100 micrometers with 0.5 millimeters of thickness. It's important to understand that the mesh should be good enough to produce a final aligner. So it's very important to have good softwares to make this the shell formation. And here are the differences between print with 100 microns or 50 microns. In my little experience, we are using 100 microns, and it feels very comfortable for the patients, and the patients say that it's very comfortable. But if you print with 50 microns, it's smoother, so it feels more comfortable. Anyway, for 100 microns, you take half of the time of printing with 50 micrometers resolution. Here are the successful printed aligners. We can see in a close view the printing process. It's really interesting to see the material. And here successful printed aligners. Here, close view of the material. After the post-curing, you can see the yellowish color of the material before the post-curing process. And then you can remove the supports. I prefer to remove the supports, lefting the supports on the platform. Just you can gently remove the aligners, and after that we can place directly on the centrifuge, and it's important that we place the aligners facing the wall of the centrifuge, and it will be after that we'll remove the supports from the platform. So 6 minutes on the centrifuge to remove all the uncured resin. This is a very important part before post-curing the process. And then we'll just remove from the centrifuge and place on the post-curing with nitrogen generator. I think this is one of the most important parts of all the process, because we need to be sure that the material is going to be biocompatible after that. So at principle, we need to have this machine, and we need to have sure that the material is completely post-cured. So 20 minutes on the post-curing process. And this machine needs to be plugged in an air compressor to generate the nitrogen from the atmosphere. Here are the aligners before the post-curing, and here's after post-curing. It is very important that the aligners must appear totally translucent. after the post-curing process. We need to boil the aligners for 1 minute to certify that everything is perfectly correct. Because if we get the aligner white or something different than translucent, maybe something's wrong, so we need to throw this aligner away and do all the process again. So this is the most important part for the production of direct print aligner. Well, there are some articles showing the biocompatibility of this material. So 10 sets of one type of aligner were immersed in sterilized deionized water for 14 days, and the cytotoxicity and estrogenicity of released factors were assessed. And in conclusion, if any factors were released during the 14-day aging, the 3D printed aligners in water, these were not found to be cytotoxics for human gingival fibroblasts and did not affect their intracellular reactive oxygen specimens levels. Moreover, no estrogenic effects of these putative elevatives were observed based on this assay. So this other article, this first one, is comparing with the first material, the TC85, and this another article is showing that it's biocompatible also the TA28. And this article, they have tested different thicknesses of the material to see if the post-curing process really worked. And they tested materials up to 6 millimeters of thickness, and they found to be biocompatible after 20 minutes of post-curing. And then we need to finish and polish the aligners. There are some parts of the supports that must be polished, and we use some tools to remove these final parts and polish. It's almost the same process that we use in thermoformed aligners. And here the aligner finished. You can see that we can engrave in the aligner the number of the aligner so the patient can see what is the stage that he's using. And then we have scan, 10 minutes, set up, 45 minutes, print the aligners with 30 minutes using 100 microns. Do the centrifuge for 6 minutes, post-cure for more 20 minutes, and polish at the end with more 5 minutes. So we'll have something around 2 hours to produce one aligner. So if the patient comes in the morning and you scan the patient, so at the afternoon you can deliver at the end of the same day the aligners for the patient. So that's the amazing part of doing in-house aligner. I don't think there's any company that will deliver the aligner for you at the same day. So that's why I love doing my own aligners. And this is the waste that we produce for 10 aligners. And I have compared with the normal thermoformed aligners. So the environment will, it's better for the environment because we'll produce less waste. And here's the clinical view of the aligners. They look like very transparent, and it's very comfortable for the patient as well. So I have some patients that I begin treating with normal thermoformed aligners, then we switch to the TPAs. Some of the patients feels very different and they like it, and I have some patients that feels the contrary, so it depends on the patient. But I have tried and it feels very comfortable. And of course, when we are dealing with 3D printing, we'll have failures. I bought my first 3D printer in 2018, and we still have failures until today. I have patients that use normal thermoformed aligners, and I have patients now using direct printed aligners, and unfortunately, we'll have printing failures. So we need to have a learning curve with the 3D printing, and it's not easy, but we must understand the possible causes of the printing failures. So one thing is we need to verify if there's any islands little islands that could cause the failures. So we carefully observed the slicing of each print and determined the need for further support. The presence of deep undercuts, the use of same tank to use for DPA, so do not use other type of resin of the printer that you are using, and maybe change the FAP of the tank, or see if the LCD of your printer is correct, so we can avoid printer failures. And compare with the traditional liners, the direct printed liners may stain a little bit more. I always tell my patients not to drink coffee with the liners or red wine because it's going to stain, but the other materials also stain too. And if you have a patient has a bruxism, it could, of course, it could perforate the aligner, but this happens also with the normal thermoformed aligner. So it always depends on the intensity of the bruxism of the patient. I normally use to change the aligners to 14 days, but depending on the cooperation of the patient, we can maybe try to change the aligners from 10 to 10 days. I never use it 7 to 7 days, but I'm okay if the patient is very cooperative to try to change the stages from 10 to 10 days. So, this article is very famous. Everybody have been seeing this long. And we know today that aligner efficiency, it's something around 50%. This study shows that root movement, extrusion, and posterior extrusion and translation are the most inefficient movements with aligners. But in general, the accuracy of tooth movement with aligners is around 50%. So, this new article from my predecessor here, Marco Migliorati, this is a pilot study from 2024 and aimed to investigate the accuracy of teeth movement or tooth movement achieved with direct print aligners. The overall accuracies of torque, tip, and rotation were 67.6%, 64, and 72 respectively. The accuracy of the change in the transverse diameter was almost 99%. Anyway, this was a pilot study and was made only with 17 patients. So I think at the end we still need more studies to really understand the accuracy of orthodontic tooth movement with direct printed aligners. Anyway, this is something that I would like to share because mastering digital CAD software is super important for us to do our treatment plans. So the aligner treatment success depends on a feasible and realistic setup. The software will accept everything, so we need to know our boundaries. And of course should be handled by the orthodontist or at least reviewed by an orthodontist. The comprehensive attachment placement and customization, determine the staging parameters. We can customize depending on the malocclusion, depending on the patient. And I also begin with the lower arch, and I use mainly the center of resistance point to make the application of the force on the software. We need to careful management the interproximal collisions and avoid antagonistic movements. Of course, we need to understand if you need to distalize a canine and rotate mesially, you need to maybe maybe do the movements separately. So I always finish all of my treatment plans with 0.1 fake IPR between every contact point. So at the end, we'll not have spaces between teeth. So, and this 0.1 of fake IPR will not do it on the patient. And artificial intelligence, it's coming now very strongly, and we need to understand all the processes. So machine learning, neural networks, and deep learning So AI will do diagnosis for us, the cephalometry and the auto segmentation and the auto alignment. So we'll save a lot of time using AI. And we need to understand better these tools because, of course, I think that we'll need the orthodontist will be continued to be needed at the end, at least to review the setup. And this is an interesting article for my moderator here. And he showed that you can access by a cone beam CT a model to really do all the segmentation of the roots and tooth together. And it's really interesting and amazing how AI is evolving. So I think we need to study more AI and understand all the process to help us save time. So this is image created by ChatGPT, and the evolution is really incredible and even scary. So today we already have a specific AI to segment teeth and auto alignment and also help with the diagnosis. So this is an interesting article, I said already. Well, as my predecessor here talks very similar to my subject, I would like to talk a little bit about the staging strategies and how we can stage with alternated patterns to have better results for our patients. So I will talk about the V staging for sequential distalization, the caterpillar staging for closing extraction spaces, frog staging for leveling the curvus P, butterfly staging for expansion, avoid intermediary collisions, so we can do also the round tripping processes to not to have intermediary IPRs, use the appropriate speed in the staging parameters, optimize anchorage, use hybrid mechanics. And this is something I have learned with my good friend from Brazil, André Drummond, and I would like to share this a little bit with you. And how to do the sequential refinements with intermediary intraoral scanning. So this is something that we are using now to do more refinements and scan the patient sequentially also. And important to decompose the movements using microstaging. So the V staging, it's a possibility to sequential distalize the tooth. And there are some articles showing that. You can see in this movie, you will distalize the second molar first, and then the first molar, then the second premolar, the first premolar, the canines, and so on. So this article shows interesting technique and the position of the attachments. This other article shows the different staging and attachment designs in maxillary molar distalization with clear aligner efficiency. And this article shows the staging. So they call V staging because of this timeline. They show like a V in the staging process, and it's a more predictable way to distalize the molars using this. Of course, we need to understand if we really need to distalize, we may need mini implants and elastics and auxiliary mechanics. The caterpillar staging for closing extraction spaces. So this also is super interesting, and it's published also, this article. And here you can first distalize the canine, and then you retract the incisors, and then you do it again. So you distalize the canines first, and then you retract the incisors instead of doing it all at the same time. So by doing this, we'll have some better results because we are using the tooth as anchorage. So you distalize the canine first, it will do some tipping, and then you correct the roots, and you can use also these anti-typing design to avoid side effects. So it's just an interesting situation to try to close better the spaces. and we can use the timeline on the software to do that. Also the frog staging for intrusion or extrusion. So if you have a patient with a deep bite, it's interesting to intrude the canines first and then intrude the incisors. It's published also in this interesting article, Deep Bite Treatment with Aligners as a New Protocol. So you are intruding the canines first without intruding the incisors, then you intrude just the 4 incisors, and then you can do this again and again until you finish your intrusion. So by doing this, and they call it staging, frog staging, because of the shape in the timeline that looks like a frog. So, but it's really interesting to have better results by using this type of strategies and frog staging intrusion. And also butterfly staging for expansion. And this is super interesting. When I read the articles and learned with my friend, we can expand first the canines and the second premolars without expanding the others. Then we stop the canines and the second premolars, and we expand the first premolars and the first molars, and we can do this 2 or 3 times to get better results. So we are using the tooth as anchorage to make the expansion. So, and it's also published in some articles, so improve of tooth movement efficiency and torque control, expanding the arch with clear aligners, finite element analysis. So they have studied this and they shown that we get better results. So this second article shows the possibility that you can do by expanding the canines and first premolars and second premolars, and then you switch to the first premolars and first molars, and you will have better results of expansion by doing these types of strategy. This article shows perception of need for further refinement in clear line treatment among orthodontists, dentists, and lay people. And of course, the orthodontists are the ones that found that the need for refinement, in some cases treated with aligners. And a strategy that we are using now is to do the refinements as a part of the clear aligner treatment. So what I'm doing now is we do some objective setups with 10 to 15 stages at maximum. And then we scan the patient every 10 or 15 stages, or every 5 to 5 months or 4 to 4 months. And then we'll do the refinement and the new treatment plan, so we can change the direction of the treatment plan. We can see if the patient is cooperative or not, and if we can change the aligners from 10 to 10 days or 14 to 14 days. So this is something that you need to have an intraoral scanner chest side. And of course, we're going to avoid loss of tracking, and we'll keep the aligners always in the best fit. We can modify and improve treatment plan directions, and we can maximize our clinical results. So this is an interesting tip that I would like to pass to you, because really we can have better results by doing the refinement. So whenever I have a patient for clear aligner treatment, I will say to him that we'll have as many refinements as needed to have the best result at the end. So I always told my patients that I can go with him whenever he left me to go. So we always want the best result as possible, but it's important for the patient to understand that we can do refinements whatever we needed. And the shape memory polymers. Everybody have seen this movie, so I've made it in slow motion so you can see it a little bit better. The material is really different. It feels different in the mouth. When you remove the aligner, you can change the shape. And when you put in the hot water, it always comes to the original form. So the shape memory effect of this material is really amazing, and maybe it's something that really makes different, and looking forward to see the results. Anyway, we have the photocurable polyurethane polymer and the reaction that heat will do and restore the shape of the aligner, the shape that it was printed. And we have a lot of studies showing the physiochemical and mechanical characterization of orthodontic 3D printed aligner material made of shape memory polymers. We have some other paper published like this one. There's a scoping review on shape memory resin for DPAs. And this one is it's really new, and the incorporation of acrylated cellulose nanocrystals into photocurable resin for high fidelity printing and transparent 3D structures. It's something that could be in the future, maybe to add to the formula of the aligner, something, for example, to treat patients with periodontal disease or to bleach some teeth, so you can use the bleaching material inside the formula to get bleaching results, or to treat a patient with periodontal disease. So we have some new possibilities that will come. And these two articles shows that the direct printed liner delivers can produce lower, more physiological force levels, and they can have a bigger amount of movement per aligner without heavy force. So this is super interesting because we can change the staging parameters, and normally we use these staging parameters, so 0.2, 0.2 to buccolingual, mesiodistal, and for intrusion extrusion 0.15, and 2 degrees for tip, 1 degree for torque, and 2 degrees for rotation. So this is the average values that we use in the normal thermoformed aligners. But by using this new material, we can expand our possibilities, and maybe can increase a little bit, and maybe we can even double it. So if we have a case with 10 aligners at the end, maybe we can do it with 5 aligners only. And this is the amazing thing about the shape memory material, that it really doesn't deliver much of force. What I can say to you about the experience with my patients is that they don't feel too much pain between the change of the aligners. And normally with thermoformed aligners, within the first 2-3 days, the patient feels some pain, depending, of course, the material are you using. We normally use PETG 0.8 millimeters for thermoformed aligners. But with this material, the patient doesn't feel too much pain. So this is interesting. And to finish our presentation, I will show something about the clinical applications and designs for direct print aligners. So before printing, we need to have an analysis on the mesh and maybe to do the customization. We can remove the undercuts in the software or another software. We can increase thicknesses. We can integrate buttons to use elastics. We can do negative attachments. We can do pressure points. And we can also do some precision cuts in the aligner. So the thing is, at the end, we can use fewer attachments. And I use this a lot in my office, the possibility of hybrid mechanics. So if you have a patient with large undercuts like this one, we can get the aligner that comes out of the software. We can enter in another software. This is a free software. It's a mesh mixer. You can remove these undercuts, and then you can customize and remove the undercuts before printing. So here's a aligner printed not doing this, and this other we have used the software to remove the undercuts. So this is just showing how the undercuts could harm the patient, and then you can remove in the software. So here's the profound undercuts, and remove it on the software. Also, we can do increase on the thicknesses of the aligners. You have seen with the same article by my predecessor here, but of course we can use various types of different possibilities with this new aligner. So here I'm using also mesh mixer to increase the thickness of just this canine, and I'm showing here how we can double the thicknesses on the buccal side to have a more better control on the torque and etc. And here we can integrate buttons. So you can import to the software the STL of the button, and then you can just place in the position that you like. If you need to place between those two tooth or in the canine or in the premolar or in the lateral region, then you can just combine both of them. You can save this STL file, and then you can print it with the button. And here is the design and the final aligner. The design, we can also make reinforcement behind the button, because as this material is super flexible, if you use a small button, maybe it will bend, and the aligner will keep, the elastic will not be in the position. By doing this and using a little more, a bigger button, this will not happen, and in the patient's mouth we can use the elastics very well. We can also see this study showing the strength in three-dimensional direct printing aligner material for a specific designing. And you can use negative attachments to generate force and moments. And even inside the software, we can do that by using this tool that you can scoop in the tooth. So we can make a negative attachment here. And then you can see on the software, and after we print the aligner, the negative attachment will be there. And here's a case where this patient was using a retainer, a fixed retainer, and has this movement of this central incisor buccally. And we just need to place this tooth back into the bone. So we are trying to use this type of negative attachments for doing this job. So we can use also the mesh mixer to place a negative attachment. It's the same process. You can integrate in the mesh and merge. So you can have a negative attachment and try to have a better result to repositioning this root in the proper position. And also do the undercuts with the trim line. So we can have the adjustable trim line, internal pressure points, negative attachments, and increase the aligner thicknesses. So these are the new possibilities with this new material. Here we can just plan and we get the same result. This with just 3 aligners. We have opened the space, and then we can use restorative to close the spaces. End-use hybrid mechanics. We can integrate traditional orthodontic techniques with aligners to improve treatment efficiency. In this case, we need to distalize this lower right side. So we have used the mini implant and brackets on the lower arch and aligners in the upper. So the future directions is that we still have advancement in 3D printing, material science innovations, and to have broader treatment applications. And of course, the AI will do something for us. So the combination of 3D printing and advanced materials expands the range of orthodontic treatments available to patients, enhancing care. And of course, we still need more studies to prove all of that. So the take-home messages and conclusions will recognize the 3D printing workflow to produce direct printed aligners in-house. We can identify the importance of the clinical expertise of the orthodontist for mastering digital planning software and propose an optimized treatment plan to increase predictability. And we need to evaluate the clinical alternatives for direct print aligners and different staging parameters. I would like to invite you all to participate on the orthodontic meeting that we'll have in Rio for the World Federation This Congress happens only 5 years, so you are all invited to come to Rio. It will be a pleasure to see you guys there. And I would like to pay a tribute for the great orthodontists that I have the chance to meet. So here's Professor Graeber in 2001 and then 2003, and again, always smiling. Here's Professor Ricketts, Charles Burston. I have 3 photos with him. And Tiziano Bacchetti, Dr. Profit, Yuri Kudal, Vince Kokic, and Tom Mulligan. So, and here's Nelson Musha, one of the greatest orthodontists ever and one of my mentors. So I would like to thank you all for the kind introduction. Here's my family. So thank you very much.
Thank you, Dr. Jacob, for a great presentation. We're now open for questions.
Thank you for your presentation. It was great.
Thank you.
I was wondering, what software do you use to design your direct printed aligners?
So we use Archform, and the exports will come already with the supports and the shell. And then after, to make the pressure points or integrate the buttons, we use Mesh Mixer. Welcome.
Hi, Dr. Jacob. Thank you for your lecture.
Thank you.
I just had 2 questions. For the undercut removing, do you remove it for all the patients or just perio patients? And does it affect retention of the aligners?
Just to the perio patients. Just when you have some profound undercuts, then I remove on the software, on the Mesh Mixer also.
Okay. And then with the expansion, when you're using Butterfly, do you get plunging palatal cuffs like that you get with the other aligners?
No, not at all. I think we really have better results by doing this. So you expand first the canine and then the second molars, and then you do that. But I got some better results by doing that.
What would you say the maximum amount of expansion that you can expect with the direct printed aligners are?
Yeah, we can almost use 0.5 millimeters per stage
I mean,
for buccal.
for the whole treatment.
You say in the staging parameters?
No, for the whole treatment, like, would you be comfortable?
I say
5
1 to 2
millimeters?
millimeters at maximum.
1 to 2, okay. Thank you.
Thank you.
Thank you for this great presentation.
Thank you.
I want to ask something. You said you use direct printed aligners, also thermoform shaping aligners. Do you use any machine for trimming aligners or by hand?
I used to do by hand, but we have some very good equipment on the market that do the trimming process. So Archform even has one. So, and there are other companies that has some milling machine, and it really speed the process and makes the aligners really smooth. So it depends on what software are you using, but there are some really nice trimming machine that does the job for you. That must be the most difficult part for in-house aligner, the cutting process. So if you have the possibility to have a milling machine, it will, of course, will be better.
Can I ask another question?
Class, of course, please.
Do you think laser trimming is toxic for aligners and patients, or
The material after you used
laser trimming actually?
laser trimming? Oh, I don't have experience on laser trimming. The trimming that we have seen is with the burr and not with laser.
Okay.
But I don't think it will do any harm on the patient, because when you cut the material, it will stay the same. I believe so.
Okay, thank you.
Thank you. Thank you so much.
Thank you so much. I really enjoyed the presentation.
Thank you.
In your introduction, you said that you have an orthodontic practice and a digital lab, so you made that distinction.
Yeah.
It's not just something on the side. I would be really interested in, Did you, as the orthodontist, set it all up? Do you now have somebody who runs it for you? How is it staffed? Just a little of the practical day-to-day running, because it's fascinating, but to get the rubber on the road is not always easy. So
Yeah.
I would love to hear a little.
And it takes a lot of time, right? So for my own patients, I normally do it all myself. But we are running a planning center for Archform, so I have a team that do the first setup, and I just reviewed at the end. So the setup is ready, and I see the attachment position and the staging strategies, so I just reviewed at the end. But I have a team that do all the job for the treatment planning, on the Archform treatment planning.
Thank you.
Thank you, thank you.
All right, so I wanted to ask about what resin do you use for your printing with the direct aligners?
It's the Graphi resin, the TA25.
And the STL files that you show on Mesh Mixer, are those available, or we have to make them ourselves?
Yeah, those STL files are exported from the Archform software. So whenever you do the planning, it will do the exact number of liners. So you export those STL directly to your computer, and then I enter in the Mesh Mixer to make the design and the.
But for example, to add the buttons for elastics.
Okay, so that button, for example, is from Morelli, a Brazilian company. So I have the STL of the company, and I just remove the base to integrate better in the liner.
Got it.
So
Thank you so
I
much.
have cut the base off of the button, and then I increase the size because the material is too flexible. So you need to have a larger button. But I have the STL from the company, the Morelli company.
Thank you, and great presentation.
Thank you, Tarek. Thank you, everybody.